joining us this morning around the world. I'm Bill Dillon. I'm one of the co-founders of Health for the World, and I'd like to welcome you all this morning. I'm speaking to you from San Francisco, so it's very early in the morning here, but wherever you are, thank you for joining us. We're delighted to have Dr. Michi Erdfarb, who is the Chief of Radiology at the Montefiore Wakefield campus and Director of Quality and Safety for the Department of Radiology. He is an Assistant Professor of Radiology at the Albert Einstein College of Medicine, and his focus is on CT and MR cross-sectional imaging of the head, neck, and spine. He's a neuroradiologist, and we're delighted to have him this morning. His topic will be on cystic lesions in the brain. So thank you very much, Professor Erdfarb, for joining us this morning. And you can share your screen whenever you're ready.
So I hope you guys can see the screen now. Everyone sees the slides? All right. So as he said, my name is Erdfarb. I'm from Montefiore Medical Center, where I'm a neuroradiologist. I'm going to speak today about intracranial cystic lesions. And what I'm going to try to focus on is sort of a broad approach to dealing with them. We'll talk during the lecture about how some of these slides or single cases actually are a whole lecture in and to themselves. That really might actually be of interest in certain sectors, but we're not going to get into all of it today. But hopefully it'll allow people to sort of have an approach when they see these things on CT and MR. So obviously, before we say anything, the big picture is whenever you're trying to classify any intracranial mass, there are certain things you have to do because the limitations inherently of CT and MR is we can see maybe densities on CT, we can see sort of signal characteristics on MR, we can see enhancement, but a lot of pathologies really do look the same. But if they're in a specific place, it helps us out considerably. When I was a resident, we very much focused on what compartment it was in, intra or extraaxial. Obviously, the differential is wildly different for a parenchymal mass, and even between a white matter lesion and, let's say, cortical mass and an extraaxial lesion. And then within the brain, sometimes things don't so nicely cut as an intra or extraaxial. Like there are pineal lesions and there are sella lesions where they have their own differential. So a nodular enhancing mass in the pineal region, you're thinking about a germinoma, whereas that same thing might be in the posterior fossa in a kid, you're thinking about a JPA. So we're going to focus a little bit on that when we look at some of these cases. Obviously, age is always going to be important. The differential for pediatric and adults are again different. A great example, again, are those, predominantly cystic but nodular enhancing masses in the posterior fossa, which in a kid you might say is a juvenile pilocytic astrocytoma, again, a very benign WHO grade 1, well circumscribed lesion that has a great, prognosis. And an adult, it might be hemangioblastoma. You might be thinking more of a VHL type of picture. Again, looks almost the same on CT and MR. And of course, history always will help. Was it something that's been there for 100 years? Do you have prior? Is it growing? Is it stable? And you'll see in some of these cases that we'll go through that you really can't tell much about it. And it's only as you follow a lesion over the course of years that you basically say, this is obviously not doing anything. Don't touch this lesion. Don't brain surgery this lesion. You'll do more harm than good. But again, only time will tell. So we'll that's kind of the overview of how to look at these things. So here's the first case. We're going to focus a little bit in the beginning on the commonest or most common lesions, and a lot of them are benign. So here's a scout image with some 3D rendering of a pediatric brain CT, and you can probably appreciate on the left side of the skull, there's this bulge coming out. That's what the patient was referred for. Mom noticed or dad noticed some funny growth. They went to the neurosurgeon and they sent them for the CT. And then when you look at the axial images, you see exactly kind of what we're talking about today. It's a cystic extraaxial lesion. I don't know if you guys can see my arrow. Can you guys see the mouse? I'm not sure.
Yeah.
Okay, so you see the cystic sort of expansile lesion, which has a lot of important characteristics. extraaxial. You also tremendous amount of herniation. There's not a lot, just to show the lack of destruction. Again, a clearly defined extraaxial mass, CSF sort of attenuating with very benign characteristics. And of course, we all probably, I think, know what this is, and that's going to be an arachnoid cyst. Arachnoid cysts are probably the most common intracranial cystic lesion you'll see. You'll see them often. They rarely do anything. They're, for the most part, do nothing lesions. In the current case that I showed you, it had some cosmetic issues, and there may be some desire to address that. But from a health issue, hydrocephalus causing herniations, it's not there. So that's important to recognize. It would be very different if there were enhancing components. If you saw a lot of edema around it, if you saw destruction of the brain, you'd be thinking about something else. The most important thing to recognize about the arachnoid cyst also is that it's not a slam dunk, though. You can have a homogeneous CSF sort of intensity or CSF density lesion in the extraaxial space. And it's not always an arachnoid cyst. On CT, we tend to call it as such. But the thing to keep in your mind is an epidermoid. Epidermoids are also low density extraaxial lesions, and that's your primary differential when you see this. Again, if that doesn't grow or cause problems, it's also not that important. But again, sometimes if somebody has symptoms or there's a question, it's worth it to get the follow-up imaging just to demonstrate the stability. Alternatively, you can get an MRI. An arachnoid cyst on MRI is going to be just simple CSF fluid on every sequence, and it will not have enhancement. So then you could have the slam dunk, whereas an epidermoid will have restricted diffusion, and we'll talk about that in a little bit. So that's the first one. Arachnoid cysts, 1% of intracranial masses. You'll see them all the time. Don't worry, lesions. Now here's another lesion, an MRI, and you see T2 brightness or T2 intensity in the fissure right over here, left MCA. And so you might think, okay, commonly people think bright on T2, that is fluid. Again, I always at this point in lecture point out to everybody that no, it could be a lot of things. T2 bright in and of itself doesn't mean it's a cyst on MRI. But we also look at the flare and we see it's sort of heterogeneous. It is certainly not suppressing as we'd expect. On the coronal T2, you see again this sort of T2 bright structure all along on the left, sort of infiltrating around in the brain. And then the slam dunk for us is going to be the restricted diffusion. Whatever this is, it's restricting. So you have something that looks like CSF sent signal, but isn't, because it's got a dirty, so-called signal on flare imaging, and has that restricted diffusion. What's important to note is it doesn't have a lot of edema around it. Were this to be an abscess, something else we should all be thinking of when you see restricted diffusion, you'd probably expect more edema around it. So putting all that together, here's an enhancement picture, sorry. It doesn't enhance, which is what we'd expect for this. It doesn't enhance. Again, on that T2 coronal, now T1 post-contrast coronal, sort of similar picture. Again, not enhancing inside, heterogeneous, not simple fluid. And this is an example of your epidermoid cyst. And your epidermoid cyst is a little bit more problematic than your arachnoid cyst. They can grow, they can be locally invasive, they can be recurrent. And when they grow, they can start causing things like hydrocephalus and midline shift, and eventually maybe some peritumoral edema. And they can either be congenital or acquired. All right, and when they're congenital, they're again due to the ectodermal inclusions. So it just keeps making all this sort of skin type stuff, and that's where your restricted diffusion is coming from. There are about 1% of tumors. Great places for epidermoids is the CP angle, the cerebellopontine angle. It's high in your differential. If you see a mass lesion in the CP angle that looks CSF, you might think on CT again that it's an arachnoid cyst. Think epidermoid. They can occur in the fourth ventricle. Other places are less common. Importantly, they are slow growing. They therefore don't sort of displace and destroy, but they'll encase, so they can get around vessels. It obviously complicates removing them. They have a little capsule sometimes, and again, what you'll get symptomatically is headaches. You'll get symptoms of herniations. You'll get symptoms of edema. And for those who like pediatrics, it's associated with so-called Curio's triad, which people are probably familiar with. So that's your epidermoid cyst. And again, just going through the signal characteristics, this is what you're looking for. And again, importantly on CT, it really does oftentimes look just like an arachnoid cyst. All right, here's another thing that confounds some of our residents when they start to really read on their own, and they'll be looking at a CT and they'll see a region of decreased attenuation. start wondering, is that a stroke, or could that be a mass? Is that some edema? And if you compare it to, let's say, an MRI, you'll look at that, and you can't really tell here. We all probably know what it is, but you can't really tell here. But on MRI, again, you see a well circumscribed T2 bright lesion without a lot of edema around it, no gliosis surrounding it, very well circumscribed. And that, of course, is a dilated perivascular space. And major differential consideration there is going to be a small vessel infarct. But for a small vessel infarct, you would expect to see the surrounding gliosis. That's if a perforator vessel gets blocked or dies due to microvascular disease, diabetes, hypertension being common. You could lose some brain. But if you don't see any gliosis around it and it looks very benign like that, it's just a dilated perivascular space, so-called Virchow-Robin spaces. They're extremely, extremely common. The one I showed there is an extremely common location. Look at these sort of inferior and lateral margins of the lentiform nuclei. These things live there. It's honestly not even worth calling them half the time. They just cause more problems if you mention them than if you didn't. The important differential is, could it be microvascular disease, right? If you see a lot of them, if you see a lot of white matter disease, it could be potentially important, right? If a patient is coming in and they have strokes or they have microvascular disease, and people are discussing whether it's worth it to do some sort of antiplatelet therapy in the context of intracranial atherosclerotic disease, these become more relevant. So it's not an entirely meaningless distinction about a dilated perivascular space versus a chronic lacunar infarct. But you want to be careful not to overcall the lacunar infarcts, because you could put people down the wrong treatment pathways with its associated risk. There are these categories called état criblé versus état lacunare. What those are different versions of seeing many of these little CSF intensity foci overlying the basal ganglia, like they have over here. And the distinction is as follows. État criblé is really saying you have diffuse involutional change, right? So over time, as people age, they sort of lose brain volume, and you can have dilation of your perivascular spaces sort of selectively. So as you lose volume in general, you just have more dilated perivascular space. That's, again, more benign. There's another concept called état lacunare. It looks similar, but you would see more of this gliosis surrounding it. And that is multiple bilateral sort of extensive lacunar infarcts. Again, same distinction from a clinical perspective that you want to make. But that's where you'll really see it. And our residents sometimes will see some of these cases and they're like, what is that? It looks crazy. And sometimes just as benign as, this guy's got prominent vascular spaces, do nothing lesion, no need for workup. So that's why it's important. And here, again, you can see there's not much gliosis around it, but this person does have some microvascular disease, but these are all just dilated perivascular spaces. Another common cystic lesion that we see, you can all see clearly here to the sort of lateral to the cerebral peduncle in the choroidal fissure, so-called. Again, the first time you see it, you'll be like, hey, what does this person have? There's asymmetry, this is a brain mass, what do I do? But it's, again, well circumscribed. It's CSF density, suppresses on T1, and then again, you can see it on the coronal T2, and it's exerting maybe a tiny bit of mass effect on the hippocampus, but really nothing to speak of. Another do-nothing lesion called a choroidal fissure cyst, very common. Look for that location, lateral to the middle cerebral peduncle. It's in the so-called choroidal fissure, which is, again, a C-shaped cleft of the lateral ventricle. It's between the fornix and the thalamus, and again, almost always lateral to the midbrain. What is it exactly? What's causing that CSF accumulation? So there's been different papers written about this where they try to do pathology and look at it, and they found all sorts of things. So arachnoid cyst, common being common, and then neuroglial, neuroepithelial cyst, which we will talk about later, but functionally benign cystic spaces, again, do nothing lesion. And you'll never see enhancement with it, and it'll rarely, if ever, cause any sort of mass effect. Certainly will not be symptomatic, is likely not the reason for the problem you might be seeing. So up until now in the presentation, we've talked about sort of the most common, very benign CSF intensity lesions you'll see. And just, with the exception of the epidermoid, which might need some intervention depending on the cost benefit of addressing it. For the most part, these are things you will see. You'll see them commonly and don't need further workup. Almost all of them can be confirmed on MR. Again, you'll be looking for a thin CSF with no enhancement, no edema surrounding it. Okay, so that's part one. Now we're going to talk about a different kind of lesion, and these are a little more concerning. You know, everyone can appreciate here that you have a somewhat well circumscribed lesion to the left of midline, which internally shows decreased attenuation, not fluid density, but less than parenchyma, less than expected, white matter, gray matter, with a ring around it of sort of increased attenuation, so almost a capsule formation. This lesion is causing a significant amount of mass effect, midline shift, probably some hydro already, maybe compromising the foramen of Monroe. This lesion is not just a simple cystic do-nothing lesion. So you have to say, well, what's the next step here? So you can make your differential. Your differential will be, of course, a primary mass in the brain that has internal necrosis, potentially hemorrhage, potentially infectious processes. So you can get your MRI, and your MRI here, you see surrounding edema, doesn't look great. Again, you see a capsule, you see internal sort of junk, which has high signal. And again, then the flare, you just see more of the edema. It demarcates it pretty well. You see the extent of it. And again, unlike some of our last ones, the most important thing here is just all of that edema, all of that mass effect, telling you it's not something so simple. You get your gradient or your susceptibility weighted imaging, whatever you use, and you see there's some inhomogeneity of the magnetic field, whether it's debris, calcification, or blood, but again, not simple at all. And then again, your kicker, it's your diffusion, and like we talked about with the epidermoid cysts, you have a lot of restricted diffusion here, right? Restricted diffusion, in common parlance, certainly in our ERs, they think, oh, restricted diffusion, that means a stroke. We haven't talked about stroke at all today, and we won't, but we've already seen epidermoids have restricted diffusion. Here's another intracranial sort of cystic lesion that has restricted diffusion. So we see that clearly. And then you have the pre-contrast T1 and the post-contrast T1. And the post-contrast T1 shows this capsule, avidly enhancing. So, we walked down the path here with the restricted diffusion. This is therefore, obviously, most likely an abscess. Right, this has all the classic characteristics. That restricted diffusion is high on the list. Could it potentially still be a necrotic mass? I guess potentially, but this is really a slam dunk for abscess. A lot of edema around it, and that's coming from the brain noticing that there's this infectious process that's sort of irritating the adjacent white matter. Generally, this will start with a cerebritis sort of picture, maybe seeded from IV drug abuse, something maybe in the bloodstream. For whatever reason, you get a bug in the brain, infects the brain, and then slowly over time, your inflammatory response will try to encapsulate it and make it a discrete abscess. From an imaging perspective, again, this just lists it. We talked about it in the pictures. It's ring enhancing, and it has edema around it. And of course, it's not simple fluid. And again, the slam dunk a lot of times is the restricted diffusion. And this is one of those things, though, abscess, which is a huge discussion on its own, because it really incorporates all the infectious processes. People are probably familiar with, cryptococcus, when you get the gelatinous pseudocyst. Toxoplasmosis is relatively common, which can present with enhancing lesions, sometimes peripherally enhancing. Hydatid disease. Again, an entirely very well described, but lots of pictures, there's different stages. The important thing to remember about a lot of these parasitic infections in the brain is in the early stages where they're just happy to live in the brain, you'll have what looks like a cystic lesion without surrounding edema, right? Until the parasite, let's say, dies and their capsule starts to leak. You might not have any edema or any symptoms, and oftentimes we'll diagnose such disease after a few years when whatever your little parasitic cystic disease was, whatever lived inside the cyst dies, starts to leak into the brain. All of a sudden you get the headaches, you get the mass effect, you get this inflammatory response. Because again, the parasites want to live in your brain. They don't want to kill their hosts. So keep that in mind, that when you're seeing that disease and you already have your edema, it's usually late in the process. Okay, for another relatively benign sort of disease, we have our neuroglial cyst. So a neuroglial cyst will look a little bit like that choroidal fissure cyst we talked about before, and that's why it was one of the things on the differential. It's another, oh my gosh, there's a huge cystic mass in the brain. It has CSF intensity on all sequences. It will suppress on the fluid attenuation inversion recovery. It will not have enhancement. It will not have surrounding edema. It may have a degree of mass effect, like in this case, but functionally, if you see that constellation, again, whether it's an arachnoid cyst extraaxially, whether it's a choroidal fissure cyst, whether it's any of those, it's again probably going to be a do-nothing lesion. It's worth getting the contrast just to make sure there's not internal nodular or soft tissue enhancement, which could really put you in a different diagnostic pathway. But once you've documented it's stable, and once you've documented it's not enhancing, you can feel comfortable saying, well, this is probably not going to be a malignant lesion. It's probably going to cause you no problems. When would it cause problems? If it continues to grow and again gives you that mass effect requiring fenestration. Sometimes they'll put catheters in these things to drain it just to keep the mass effect down. But for the most part, it's a local disease, not a systemic disease. So these are generally glial lined. They have a number of names, as you can see on the slide: glial ependymoma, neuroepithelial cyst. This is in distinction to a different kind of intracranial cyst called a neuroependymal cyst, which is lined by ependymoma as opposed to a glial lining. Again, these are pathologic distinctions that generally you won't be able to make on MRI alone. Okay. A similar lesion, but different in a lot of ways, is this one. Again, here we have an axial T2 sequence, which shows a predominantly normal brain, but then this right parietal lesion, all of a sudden it's all, again, CSF bright, CSF signal, T2 bright, with a loss, but what distinguishes it from the last case is we don't see just mass effect maybe in, compression of the cortex. We see lack of cortex. We see lack of normal brain. And we also see some adjacent gliosis, which is important as well, because it tells us that there was some injury here. All right, so this is not a simple cystic lesion of the brain. This is a parenchymal lesion where for some reason you lost volume. This is a sagittal. Again, it just shows you a little bit better the amount of gliosis and encephalomalacia associated with this lesion. But again, no mass effect, no midline shift. Here's a similar case where you have, it doesn't go all the way to the margin, but it does communicate with the ventricle, obviously CSF density. Again, on the coronal T2 to show you the margins, you can see pretty clearly there's loss of a lot of the white matter. And this is a so-called porintophallic cyst. It's an intraaxial lesion, right? This is not, even though it looked like it went to the all the way to the surface of the skull there, to the inner table, you have to realize that this is an intraaxial lesion, again, demonstrated by the gliosis surrounding it. And when you have that constellation of communicating with the ventricle and volume loss and gliosis, you think of a porintophallic cyst. And it oftentimes is a result of an in utero trauma or some sort of infarct, maybe hemorrhage, maybe infection. There are a couple of things that can cause this, but overall, it kind of gives you this picture of, for some reason early on in life, you lost it. Oftentimes, this will be incidentally demonstrated. Patients might have reprogrammed, rewired, because it's so young when these insults happen. They may never notice it. It might be found incidentally on a CT or an MR, in which case you can be very reassuring and say, listen, you lost volume when you were young, but this is not an example of some horrible tumor or progressive disease. All right. These will be white matter lined generally, as opposed to a picture I'm showing here, which is another CSF density structure here, which probably everyone in this call is familiar with at this point, but it's, instead of being lined by white matter, it's lined by gray matter. And this obviously is a schizocephaly, and a schizocephaly is not due to focal volume loss like an infarct or a hemorrhage or an infection or any of that sort of thing, but rather it's due to a developmental anomaly where you have a mistaken sulcation, and for whatever reason the brain doesn't come together, and you have this persistent cleft, and these can be symptomatic. So you don't want to confuse those two, because again, you have it communicating with the ventricle, going all the way to the inner table. On CT, sometimes it's difficult to tell. This is a nice MRI, obviously contrast enhanced. You can clearly see the gray matter, but sometimes on CT, it's not as clear. So it's worth the workup if you see this. Okay. Next case is, again, a pediatric brain. And when I give this lecture to the residents, I always say that the only important thing you're going to do in the ER setting here is you'll recognize that there's a mass, obviously. But the mass is not the important thing here. The important thing, obviously, is the hydrocephalus. That's the thing that puts this child at risk, immediate risk and harm. So before you worry about what kind of pediatric tumor or what kind of posterior fossa tumor this is, your first phone call is to the ER to let them know, call neurosurgery, let's get a catheter in there. We don't want to herniate. But then for the more academic question of, well, what is this? What could this be? So again, it's a partially cystic, partially solid mass in the fourth ventricle. And again, you can tell it's sort of a pediatric patient. MR, which of course will be the next step here, shows again a cystic region and this sort of nodular region. This is a very large nodule. A little bit of edema around it, obviously a tremendous amount of local mass effect, not a tremendous amount of edema everywhere though. Again, you see a little bit on this side. This is mostly the mass itself having some edema, but around it, the brain is not that upset about having this mass here. It's not having a huge inflammatory response surrounding it. It does not restrict diffusion. So you're thinking, okay, so it's not probably an abscess. It's not my epidermoid, not that it would be there. It has a little bit of susceptibility related signal loss, so some degree of internal heterogeneity, again, maybe mineralization, maybe a little bit of hemorrhage in the nodular component. And then enhancement. So on T1 pre-contrast, dark. On contrast, very sort of avid heterogeneous enhancement in the nodular component. And we talked about this a little bit at the beginning of the lecture. This is a sort of a classic juvenile tumor called a juvenile pilocytic astrocytoma. It's a benign, to a certain extent, grade 1 astrocytoma. They're generally well encapsulated. These resect pretty well. It's not the worst diagnosis. If you have this, we deal with the hydrocephalus, they resect the tumor. Oftentimes they don't recur, and a child with this sort of disease will likely have a normal life. They typically show up in the posterior fossa. They typically have a cystic component. That's not to say they haven't been documented places with no cystic component whatsoever, which in the posterior fossa could get confusing for something like a medulla or something on that spectrum. But they're also, again, like I say on the slide here, you can see it in the CP angle. We've seen them sort of everywhere. It's just a WHO grade 1 though. So if it's recognized and it's not causing the mass effect and it hasn't done anything bad, there's excellent prognosis for these tumors. They're by far the most common pediatric intracranial tumor. And again, slow growing, well circumscribed, not a lot of edema generally. They have that benign appearance, but not nearly as benign as, let's say, the cystic stuff we talked about earlier. A cyst with a nodule is sort of classic. Again, like in our case, there could be some hemorrhage or calcification in the nodular component, which we had. And again, the solid component could be just a small homogeneous nodule, or it could be like our case here, which was a larger heterogeneous nodule that demonstrated heterogeneous enhancement. There is a differential for cysts with nodules, and I think it's important to point out because we're not going to go through all these different cases, and some of them are dependent on age, some of them are dependent on location, like we talked about in the first slide of this lecture. Ganglioglioma is a common one. You'll see these in the temporal lobe. For people who do a lot of epilepsy work, it's common to see. It's a common epileptogenic tumor. Also can look like a cyst in a nodule. Could be solid, it could be a cyst in a nodule. The PXAs, also cortical tumors related to, that might be related to seizures, might have that appearance. In an adult particularly, we talked about earlier on, again, a cyst in a nodule, posterior fossa, you think about the hemangioblastomas in the context of VHL is oftentimes where they're thought of. Neurocysticercosis, has many stages, and we're not going to go into that today, but some of them are cystic nodules, so you can think about that as well, depending on the population. The reason, again, we showed the restricted diffusion shot was to show that there was no restricted diffusion. This is probably not an abscess. Again, if a JPA is entirely solid, you might think about a medullo. And then there's, ependymoma is another posterior fossa tumor in children. Again, not cystic, has sort of, characteristic appearance in the ventricles, like the so-called toothpaste appearance going down, and then ATRT. But again, our case here is just sort of the straightforward version, which is just a cyst in a nodule, not a lot of enhancement, your JPA. Here's another case of a cystic lesion in the posterior fossa, shows CSF density, a little bit of mass effect, and then on the contrast, right, you don't appreciate it here. Here on the CT, you might think maybe just an arachnoid cyst and suprasellar cistern or quadrigeminal plate cistern, or depending on where we are exactly. But on the MRI, you see this very clear nodular enhancement. This is an adult patient, so instead of a JPA, we're thinking more of the hemangioblastoma. Again, also grade 1. It's a vascular lesion. It's a vascular lesion, sorry. It's a vascular lesion, and they're almost predominantly seen in the posterior fossa in adults. If you have von Hippel-Lindau, you'll start to see them in other places. Supratentorially, you'll see them on the spinal cord. One of the things that makes them somewhat easy to identify is they tend to have a tremendous amount of associated edema, especially in the spinal cord. So if you see that lesion, it would move you in that direction. They make up about 10% of posterior fossa tumors, again, 2% of all intracranial, like I said here. They're generally sporadic, but again, if you see them supratentorially, you see them in the spine, it starts to get the wheels turning. Is this a VHL patient? So differential, of course, metastatic disease, and a lot of the primary intracranial tumors, I mean, GBM can present like this. So there is workup, there's workup that you have to do for this. You have to make sure that you're not missing something that's a little bit more concerning. But if you see there are sort of this constellation of findings, again, sort of expansile, nodular, mostly cystic, you can think in terms of these sort of WHO grade 1 lesions initially. And again, your job is really to make sure, is it somewhere else? If the physicians ask you, what else we can do, you can recommend like a spinal imaging, you could recommend follow-up. These are always good things to do with any of your intracranial cystic lesions, just to make sure that they don't develop into something more concerning. Again, medulloblastomas do occur in adults, again, in posterior fossa mass, and they can have cystic components. So also keep that in the back of your mind. So if we go back to sort of the long picture of the last half hour or so, you see that there are different lesions that can occur in different places. If you have your extraaxial masses, you go in one direction of a differential. Intraaxial masses, another direction. And then, of course, super and infratentorial, and then adult and pediatric. And if you try to like kind of bucket these things into one of those categories, or one or more of those categories, you'll be able to sort of craft a differential that can help both determine what the initial management should be and what the appropriate follow-up should be. And that's what the clinicians usually will want. If you have an ER case particularly, they want to know what to do next. And if and when we can clear things and just say this is nothing to worry about, like the choroidal fissure cyst, like a dilated perivascular space, you're doing the patient a big favor. What we don't want to do too much is overcall and call everything a tumor. That puts people down in a road they don't necessarily want to be in. And we also don't want to be unnecessarily reassuring. Like in the hemangioblastoma case I showed you a minute ago, on the CT, it looked relatively benign, but you don't want to sort of pass that. You want to recommend the MRI. You want to get the follow-up. All right. I think that was it for what I had prepared for today. Or do we have any questions that I could address?
Thank you so much, Dr. for that excellent lecture. Very good overview. As of now,
I can't, somebody's speaking, but I can't hear them.
That was terrific, Dr. Erdfarb. Thank you so much. We have 143 participants, and I think, Rafi, are you going to manage the Q&A?
Yeah, are you able to hear me right now?
We can barely hear you, but that was just absolutely terrific. I appreciate it. I think one important point that you made that I think is so key is the use of diffusion, and that's been very important in our practice. And it's a routine sequence that we use on every brain sequence now. And I just wondered if you had the same feeling. And
yeah, we include diffusion pretty much in any of our protocols. At our institution, we have a bunch of sort of routine MRI brain protocols that we use, commonly, to look at the cella, IACs, some of the pediatric stuff for hydro. We almost always included diffusion at this point because, like I kind of referenced early on, although in common parlance, certainly our stroke neurologists use diffusion as just a stroke tool. We're finding more and more that within tumors, There's utility, right? This concept of hypercellular tumors showing a lot of restricted diffusion, which may or may not have some prognostic implication, but not just for tumors, for these distinctions like for epidermoids and for abscesses, we get a lot of benefit out of it. It's not that long a sequence to acquire. Oftentimes people can't sit for MRIs, but almost everybody can sit for a diffusion. And you'd be surprised at how often we have patients that get a diffusion and maybe one or two other sequences before losing the ability to continue. And that limited imaging is absolutely diagnostic. They don't need the other 40 minutes. And we're starting this spine as well more and more.
Right. Right. I think that's a very, very important point. You know, if you have an uncooperative patient and you're designing the sequences, it's, you know, it's diffusion, it's maybe flare, a T1, and make sure that you've got those right up front, because if the patient can't cooperate, you've really got a great chance of making a diagnosis. In fact, I think if you look at the various sequences we perform, and it's probably on the order of 10 to 15 sequences sometimes in patients, one can make a diagnosis after you know, maybe 3 to 4 sequences, and diffusion is really key here. Gives you an idea also of metastatic disease in the bones, and it's a great sequence. So I think, you know, it's part of our routine.
Yeah, and it's also important when you're dealing with situations where you have limited resources. Like in the U.S., we kind of have the biggest problem. We have so many MRIs floating around everywhere. Everyone can get 3-hour sequences, but there are a lot of countries where you have a lot less MRs, and you can't allow people to stay on them for 6 hours or 3 hours or 2 hours, and you want to really move it forward. Where if you knew, again, just like based on some of the things we talked about, if you had a lesion that you had a reasonable differential on, you can very easily sort of tailor your protocol to a diffusion, maybe a flare, maybe just a contrast MR, post-contrast sequence, and you'll get 90% of the information you need to adequately triage what should happen to this patient next. You don't need everything on every patient.
One question from the panelists, Fatma Ali Omar asked, can arachnoid cyst undergo hemorrhage? And I actually have seen that before. Have you, Dr. Erdfarb, had any?
Yeah, so it's rare. I mean, there's no good pathological reason for that other than maybe again, when you have an arachnoid cyst, it's usually a split in the arachnoid membrane that slowly starts to fill up with CSF. That constant pulsation is what gives you the scalloping of the intertable. It communicates with the CSF space. And of course, there are little vessels that line that, and it may be that one of those vessels can bleed into it. Again, I've seen it, if ever. I don't know even that I've really encountered it. I'm trying to think back. And I don't know that it has big clinical implications. It should be self-limiting, unless, of course, it grows. But for the most part, arachnoid cysts are sort of do-nothing lesions unless they have, like in our case, a cosmetic issue or infrequently they could, in theory, have mass effect. But again, rarely. Generally, if we have something that we think is an arachnoid cyst that's doing something bad, by the time we get the MRI, we do find out that it's like a CP angle epidermoid or something in that regard.
Right. So I have seen a couple of arachnoid cysts give rise to subdural hematomas. I think that they probably, as you say, either minor trauma occurs or what have you, and a vessel ruptures. And the arachnoid cyst normally, which exists, you know, within the arachnoid, can break out into the subdural space, either giving rise to a subdural hygroma or hematoma. Very rarely, though. Most of the time, as you say, these are sort of do not touch lesions, usually in the temporal lobe, and it's rare for them to really cause significant mass effect, although they can on occasion. And as you say, it's usually one of these things where you recognize it and worry about the etiology of whatever the patients come in for, headaches or what have you. And I think most of the time they, you know, if on the occasion that we've done CT myelography or, you know, cysternography, they rapidly fill with contrast. Mm-hmm. And also someone asked, can they get super infected? And I personally haven't seen an arachnoid cyst get infected. Have you?
Again, I've never seen it. The question always can. I mean, if there's a blood vessel there and there's some bacteria in it and gets out, I guess it's possible. Again, I haven't ever seen it. Again, usually if something bad's happening, like it's because it's something else. I mean, two good examples are where, people, again, and we didn't talk about it in this lecture because they're more specialized, but again, those sellar or in the pineal region, you might mistake something that and think that's an arachnoid cyst in that region, where really it's a cystic either sellar or pineal region, and they can get nasty sometimes. They could be germinomas, obviously microadenomas, craniopharyngiomas. I mean, the whole other cadre of cystic lesions that live there. But generally, arachnoid cysts themselves are, again, rarely. I don't think I've ever seen them hemorrhage. I don't think I've ever seen them get infected. They're common. They're benign. You sort of leave them alone.
There's some other questions in the Q&A box. What are the diffusion characteristics of hydatid cyst in different stages? And I have not been able to answer. I wouldn't be able to answer that question. Have you seen that?
So again, we don't get a lot of that in the U.S., certainly where we are. I don't recall them offhand. I would not be surprised, though, if at certain level of stages they did restrict. I think that would make sense with the general pathology of it. But again, that's almost a different lecture. There's, I think, four different stages. At each stage, it's sort of a different imaging findings. Each stage has different sort of pathological processes that aren't in the adjacent brain, kind of like we discussed. So I would assume it's variable depending on that.
Yeah, I don't think I've seen it either. So we'll have to go to the literature on that one. Is there a place for spectroscopy in cystic brain lesions?
So yeah, there's a place for it. I mean, spectroscopy is still, it's used. We like it in tumors, so the choline creatinine, obviously, for the rapid cell turnover. You could look for certain metabolites, specifically the lactic acid for the abscesses, and people are every so often publishing new papers with, again, a new peek about some new sort of thing they're looking at that can be associated with abscess. I would say its utility, if you can get a good spectrum, maybe along the capsule of a lesion, help you determine, is this maybe a rapidly proliferating neoplastic direction versus something that looks more like the capsule of an abscess. It may be helpful. I find spectroscopy in these cases to be more confirmatory than primarily diagnostic, though. So when you have a good differential and you sort of know what you're looking at, and you think and you have a good idea, and again, you can get a good spectrum of it. It depends if you're doing multivoxel or just a single voxel, obviously. But if you can get a good spectrum of what you want to look at, and you capture a lot of good tissue there, sometimes it can provide information. Again, we don't
I rarely find that it's helpful in terms of decision making.
Yeah.
More of an intellectual exercise. How frequently have you seen a cyst of the cavum septum interpositum? And can you also, the second part of this question from Dr. Cesar is, how about pineal cyst and differentiating it from pineal gland malignancy? That does.
So there's two parts to that. So as far as along the septum, occasionally you'll see bulbous sort of expansion there. I never know if that's really a true cyst, meaning an encapsulated something with, an epithelial layer around it, or just, again, a velum interpositum, or cavum septum pellucidum et virgae, or all these sort of, congenital variations of the septum pellucidum not entirely fusing together. But I think there are cases of cysts there. Again, unless they cause hydro, mostly a do-nothing lesion, their signal characteristics, again, will just look like CSF with nothing around it. The pineal lesion thing is a trickier question. If you see, and I think what we use here, and I think it's pretty common, if you just see a well-circumscribed, non-enhancing pineal region cyst, not causing mass effect on the tectum, not blocking the cerebral aqueduct, with no enhancement around it, less than a centimeter, I just ignore them for the most part. After they beat that 1 centimeter or so size, it's worth it to follow them just to make sure that they don't progress, they don't cause the hydro, and they don't develop internal enhancement. One of the tricky parts with the pineal cyst, let's say 1 centimeter, is it's so closely approximated to the internal cerebral veins and straight sinus and vein of Galen that what you might see posteriorly along the posterior sort of superior margins of a pineal cyst, what looks like enhancement. And I personally found cases where it's very difficult to distinguish, is this real internal enhancement, nodular enhancement, soft tissue enhancement, which would raise a bell for something like a germinoma, or is it just the internal cerebral veins look a little funny and come around the sides? So even if it's not a centimeter, maybe 8 millimeters, 7 millimeters in those cases, we'll tend to follow them just to make sure that what we're seeing is just venous enhancement. The tricky part is with the patients, because you don't want to overly alarm them. I think it goes without saying. And you know what I often will tell the referrers is, my gut tells me this is not real. Let's just get the follow-up. You don't have to ring any bells about germinoma and drop meds and all sorts of badness at this point. Just tell them there's something we're going to clear by looking at that later. So that's kind of our general approach to pineal cysts. If after multiple repeats it's rock stable and never causes any problems, I think at least most people in our practice, including the endocrinologists, are happy signing off on that. I will caution though that, you know, like thyroids, which we didn't talk about, thyroid nodules, you know, radiology as a specialty have our own recommendations. We have our own white papers how to do it. These are often at odds with the other clinical specialties like endocrinology. And I you know, encourage when you see these pineal lesions, especially the indeterminate ones, the ones that look very cystic, maybe a questionable enhancement, oftentimes there will be other literature, both in neurosurgery and endocrinology, that your referrers will want to consult before they make their final decision.
Thank you. Yeah, and there was one question in the Q&A about delayed enhancement of the pituitary cyst, which does occur, benign pituitary cyst. So if you, which I have seen with gadolinium, you know, entering the cyst in a delayed fashion, it doesn't necessarily follow that that's you know, abnormal. And so these can be tough, and there's no question, I completely agree with you. Sometimes, particularly when they're a bit large and maybe a little heterogeneous, we need to follow them. You know, obviously, if there's symptoms related to hydrocephalus or any edema around them, then that's a real you know, red flag.
Right.
Another question was the patient that you had with a pilocytic astrocytoma, was there middle fossa cranial arachnoid cyst as well?
Yeah, there was. That's a good pickup. I don't talk about it, but yeah, left anterior middle cranial fossa. Incidental. Again, when I give these to residents in not this format where it's more didactic and we go through it, we talk about a lot about that, particularly about the fact that in that case you'll see there's mass effect. It's pretty impressive mass effect, but that doesn't mean it's bad. There's no herniation. You know, there's some more pictures I could have showed about that case. There's no uncle herniation, and there's also no edema. So another one of these, oh my gosh, it's a 3-4 centimeter mass exerting mass effect on the temporal lobe. Sounds bad in words, not bad at all. The important thing there is really the take home was call the ER, get the ventricular catheter in there, decompress the brain before they herniate. Step 2, try to classify your mass. And step 3, don't make a big deal about the arachnoid cyst.
Yeah, exactly. Well, I think one final comment is that, you know, when in doubt, it's better not to assign a diagnosis that you're not sure of, but actually it's okay to follow up a patient in a couple of weeks or a month or what have you, and see what happens over time. So listen, I'd like to thank you very, very much. It's a delight meeting you, and at least virtually. And I can tell you that the 140 or so people from around the world have been chatting in the chat room, and they've all very, very much enjoyed your lecture, as did I. So I want to thank you very much from Health for the World, and also on behalf of all of the panelists who really got a lot of great information from you today. So thank you so much for your wonderful lecture.
Appreciate it. I'd like to thank everyone for having me, sort of listening to me for a while. Very fun for me as well to sort of get involved in this. So much appreciated. Good to meet you all.
Terrific. And thank you all from around the world for patching in, and we hope that all of you are safe, and that a vaccine is coming to your country as soon as possible. Thank you very much.